Assalamu alaikum. I welcome you back this lecture. So today's topic is the regulation of blood glucose level. So let's start that. So as you know, the main regulation of blood glucose happens via the endocrine hormones that are produced by the pancreas, or the hormones that are released by the islets of Langerhans. That is the alpha cells which release the glucagon, the beta cells which release the insulin, and the delta cells which release the somatostatin. So all of these hormones, they work in accordance with each other to regulate the blood glucose level. So we're going to look into details of this. How does this happen, and how any disruption in their ratio or in their quantity can cause hypoglycemia or hyperglycemia and then lead to different diseases. So normal blood glucose level is 80 to 110 milligrams per deciliter of blood. Normally we say that while fasting, when the patient has not eaten for more than 2 hours, the normal blood glucose level would be between 80 and 110. If it is more than 126 milligram per deciliter, or some books say more than 140 milligram per deciliter, we may label it as a pre-diabetic or a diabetic patient. More than 140 is obviously diabetic. If there are other signs and symptoms, and 110 to 126 is pre-diabetic. So the blood glucose level between 180 and 110 is maintained by different organs. The main organ that maintains the blood glucose level at its optimal level is the liver. So the liver functions as an important blood glucose buffer system. How is it able to do that? Basically, there are different processes which happen in liver, such as the glycogenolysis, the breaking down of glycogen, or the glycogenesis, formation of glycogen. Then there is gluconeogenesis, formation of glucose, as well as glycolysis or breaking down of glucose. Now, this glycolysis happens all over the body, but the formation of new glucose, that is glycogenolysis, sorry, gluconeogenesis only happens in liver. So that is why liver plays a very important role in the regulation of blood glucose level via maintaining a steady level of stored glucose, that is glycogen, as well as available glucose, that is glucose in the blood. Moreover, both insulin and glucagon function as important feedback control systems for maintaining a normal blood glucose concentration. So what would happen here is, whenever there is increased blood glucose level, more glucose would enter the beta cells of the pancreas. More insulin would be released from there, whereas it would inhibit the release of glucagon. If the glucose level is lower than the normal level, insulin release would be inhibited and glucagon release would be promoted. So this is how the system works. Moreover, hypothalamus stimulates the sympathetic nervous system to release catecholamines, which would stop the insulin from its work and make more glucose available during the periods of stress, during fight or flight mechanism. Moreover, there are other hormones which would work in accordance with all these hormones as well as organs. The other hormones are the growth hormone and the cortisol. So all of the stress hormone, they work in accordance with each other to promote the availability of more and more glucose in the blood, as well as breakdown of proteins and fats in the blood. So the main function of the stress hormones is to provide more and more energy to the body via making more glucose available, more amino acids and proteins available, and more fats, triglycerides available. So first let's look at the functions of the liver and glucose regulation. So the first thing that we're going to elaborate on now is the glucostatic buffer function of the liver. So what happens is, all of these things I've explained to you earlier. We are going to just go through these things once again. So when blood glucose level rises after meals, when we intake food, glucose gets absorbed through the intestines into our blood. The liver stores the excess glucose, almost all of the glucose that is available right there and then, in the form of glycogen. Glycogen is the stored form of glucose. And when the blood glucose level falls during the periods of starvation, that is when the meal is all digested and it's been about 4 to 5 hours after we've taken the meal and our body is undergoing starvation period, then the liver breaks down this stored form of glucose, that is glycogen. After breakdown of glycogen, glucose would be released in the blood, and the body can keep on producing ATP, generating ATP and energy from this available glucose. So this is how the liver functions in the glucose regulation. Then there is the feedback control of both the insulin and the glucagon. So when concentration of glucose rises in the blood, insulin is secreted in more amounts from the beta cells. We've studied this mechanism in the last lecture when we were studying insulin. So insulin is secreted from the beta cells. This insulin stores more and more glucose into the into the cardiac muscles, into the skeletal muscles, as well as liver, as well as it has functions on other parts of the body. So it would eventually decrease the blood glucose level. Wherever if the blood glucose level is is uh, declining the normal amount, there would be increased glucagon secretion from the alpha cells, which would increase the blood glucose level by making more and more blood glucose available from the liver. They would promote the glycogenolysis as well as gluconeogenesis. So the function of glucagon is as such. So both of these hormones, they would support each other. They would work in accordance with each other so that the glucose level can remain normal, and it can be controlled in a steady state between 80 and 110 milligram per deciliter. Then there's the role of hypothalamus. So what happens is, whenever there is low blood glucose level in the hypothalamus, this state occurs in severe hypoglycemia when the blood glucose level gets below 60 milligram per deciliter. So in severe hypoglycemia, hypothalamus would stimulate the sympathetic nervous system. Due to stimulation of sympathetic nervous system, catecholamines would be released from the adrenal medulla. We studied this as in the adrenal gland when we were studying that 2 or 3 days ago. So epinephrine, norepinephrine would be released from the adrenal medulla, and they are stress hormones. They would increase the blood glucose level by breaking down the glycogen, as well as stimulating the liver to produce more and more glucose, as well as breaking down the proteins and the fats. Now the role of growth hormone and cortisol in prolonged hypoglycemia. So as we know, growth hormone and cortisol both are stress hormones. So when hypoglycemia becomes prolonged over the period of hours and days, growth hormone and cortisol would be secreted. They work for a longer period of time as compared to the catecholamines, glucagon, or insulin, which have short span for which they'll work. So growth hormone and cortisol would decrease the rate of glucose utilization in the body and increase the fat utilization in the body, and this in turn would return the blood glucose concentration towards the normal level. So now we can see how much importance does the regulation of glucose hold in the body? Because glucose is the main source of energy, main source of ATPs for all of the cells, all of the organs in the body. That is why it is controlled via 4 different mechanisms: via liver, via insulin and glucagon, via hypothalamus and catecholamines, as well as the stress hormone, so that the level of the glucose in blood can remain optimal. So any discrepancy in the one system can be managed by the other. But if the discrepancy is larger and the other systems cannot compensate for it, then the patient would show the signs and symptoms of hyperglycemia or hypoglycemia. So now let's study about the applied physiology of the pancreas, that is the diseases of the pancreas. So first and foremost, the most important disease is the diabetes mellitus, जिसे उर्दू में ज़ियाबतीस कहते हैं या शुगर कहते हैं. So diabetes mellitus, I'm going to start now. So if you have any questions till now, please post it in the group. I'll inshallah answer those questions in the next lecture. And let's start diabetes. So diabetes mellitus is a syndrome of impaired carbohydrate, fat and protein metabolism caused by either lack of insulin secretion or decreased sensitivity of the tissues to insulin. So we know that insulin is important for the regulation of glucose. How does it act? We know that too. It would open up GLUT2 receptors that would promote intake of glucose into the cells. It would decrease the extracellular fluid concentration as well as plasma concentration of the glucose. So what happens if the receptors of insulin, which would have attracted the GLUT hormones, stop responding to the insulin, or the insulin is not being produced in the body in normal quantities? Glucose would start building up in the blood. That condition is known as hyperglycemia. Increased serum glucose level or increased blood glucose level is hyperglycemia. Moreover, insulin also has a role in maintaining the fat concentration in the blood, as it promotes the deposition of fat in the adipose tissue. So there would be hypercholesterolemia. So there would be impaired carbohydrate, that is glucose, fat, cholesterol, as well as protein metabolism due to either the lack of the insulin or decreased sensitivity of the tissues to the insulin. There are 2 general types of this disease, diabetes mellitus. And remember, diabetes mellitus is a syndrome. It is a multi-systemic disease. It does not affect just one organ. It damages the whole body, involves multiple systems, and has detrimental effects on all of the vital organs of the body as well as peripheral tissues. That includes the nerves as well as skeletal muscles and other tissues. So it is of 2 general types, type 1 and type 2. Type 1 diabetes mellitus is caused by lack of insulin in the body. So there would be no more insulin secretion from the beta cells. Whereas type 2 diabetes mellitus is caused by decreased sensitivity of the target tissues to the metabolic effects of the insulin. So insulin would be secreted maybe in normal amounts, but that insulin would not be able to act on the end organs, on the end tissues, due to decreased sensitivity of receptors of the end organs. The reduced sensitivity to insulin is often called insulin resistance. So in type 1 diabetes there is no insulin secretion. In type 2 diabetes there is insulin resistance. So insulin is being produced, but The receptors on the end organs are resisting this insulin. So in both types of diabetes mellitus, metabolism of all the main foodstuffs is altered. So glucose would not be regulated as it should be. Fats would not be regulated, proteins would not be regulated, food cannot be particularly completely processed. So the basic effect of insulin lack or insulin resistance on glucose metabolism is to prevent the efficient uptake and utilization of glucose by most cells of the body except those of the brain. Only brain would be able to function properly. It would not have any effects due to increased glucose level. Apart from the brain, all the other organs would be severely affected by the increased blood glucose level. As a result, blood glucose concentration would increase in the blood. There would be no utilization, no storage in other cells, and cell utilization of glucose would fall increasingly lower, and utilization of fats and proteins would be increased. So to sum all of this up, there would be more glucose in the blood, that is hyperglycemia. There would be more fat in the blood, that is hypercholesterolemia. Okay, there would be more breakdown of proteins, which would cause muscle wasting, pains in the muscles, etc. Okay, now let's talk about the first type of diabetes mellitus, that is the type 1 diabetes mellitus. Type 1 diabetes mellitus happens when there is injury to the beta cells of the pancreas or diseases that impair the insulin production from the beta cells of the pancreas. So in type 1 diabetes mellitus, either the beta cells are destroyed or they are impaired, they cannot produce insulin anymore. So viral infections or autoimmune disorders may be involved in the destruction of the beta cells in many patients with type 1 diabetes. So it can be a byproduct after a viral infection which would destroy the pancreatic beta cells, or due to or body destroying the beta cells on its own, or due to autoimmune processes, autoimmune disorders. Remember, heredity also plays a major role in type 1 diabetes mellitus in determining the susceptibility of beta cells to destruction by these insults. So if a patient has family history of type 1 diabetes, his grandfather or father or mother or uncles have type 1 diabetes mellitus, he would be at a higher risk of developing type 1 diabetes mellitus. The usual onset of type 1 diabetes occurs at an early age, and for this reason it is often known as juvenile diabetes mellitus. So remember, type 1 diabetes can occur in a 3-year-old child or a 17-year-old adult. So in the early age 3, 4, 7, 10, 13, type 1 diabetes mellitus can occur, could initiate. That is why it is known as juvenile diabetes mellitus or the diabetes mellitus of the children. Okay, so main age group where it starts is young age, in teenagers or in small children, 3-year or 5-year-old children. Whereas type 2 diabetes mellitus is common in adults, and it is a far more common condition than type 1 diabetes mellitus, which accounts for about 90% of all the cases of diabetes mellitus, only 10% in type 1, 90% in type 2 diabetes. In most cases, the onset of type 2 diabetes occurs after 30 years of age, often between 50 and 60 years of age, and the disease would develop gradually, whereas type 1 diabetes is sudden in onset. Therefore, this syndrome is often referred to an adult onset diabetes. So type 1 was juvenile, type 2 is known as adult onset diabetes because it occurs in older age in adults. Type 2 diabetes, in contrast to type 1, is associated with increased plasma insulin concentration. So there would be increased insulin being secreted by the beta cells, but that insulin is not being able to do its function. It is not acting on the tissues. So what happens is the target tissues become resistant. The target tissue receptors become resistant to this insulin, or they are not acting according to the mechanism they should act. They are not generating the effects that should be generated when insulin attaches to those receptors. So when this is not happening, the pancreas would try to mitigate this situation by producing more and more insulin. So there would be increased insulin level in the blood, that is known as hyperinsulinemia. So there would be increased plasma insulin concentration, which would be in compensation by the pancreatic beta cells for diminished sensitivity of target tissues to the metabolic effects of insulin. And this is often referred to as insulin resistance. Some causes of insulin resistance include obesity. So in overweight individuals, especially if there is excess visceral adiposity, the viscera, the organs, contain too much fat, as seen in obese individuals and fat individuals with increased BMI. Insulin resistance can occur. Moreover, in excess glucocorticoids, such as in Cushing syndrome or steroid therapy, if the patient is taking external steroids, as in some patients of their autoimmune diseases, or the patient is suffering from Cushing syndrome, where cortisol is being released in huge amounts, these excess glucocorticoids would also cause insulin resistance. Or in excess growth hormone production, such as in acromegaly, gigantism, type 2 diabetes can occur. Moreover, in pregnancy there is increased insulin resistance, and this type of diabetes is known as gestational diabetes. It usually subsides after the pregnancy ends, but sometimes it can transform into the type 2 diabetes and may continue even after the pregnancy. Moreover, in polycystic ovarian disease, where there are multiple cysts found in ovaries of the females, type 2 diabetes mellitus may occur, or increased insulin resistance may occur that may lead to type 2 diabetes. Moreover, the receptors which are present on the cells, target cells, may themselves get mutated and they may not respond to insulin correctly, or in autoantibodies production to the insulin receptor, which would destroy the insulin receptors. In this condition, type 2 diabetes can occur if the body produces autoantibodies against these receptors, insulin receptors. Now let's look at a chart of differences between type 1 and type 2 diabetes mellitus. So generally, type 1 diabetes mellitus is only 10% of total diabetes mellitus cases, whereas type 2 diabetes mellitus accounts for about 90% of diabetes mellitus cases in the world. Age of onset of type 1 is usually during childhood in small children, whereas type 2 is more common in adults. Type 1 diabetes mellitus patients usually have normal or low weight. So there is no correlation, but type 2 diabetes mellitus mostly occurs in obese individuals. Moreover, type 1 diabetes mellitus, if treated correctly with insulin clinically, it has rare complications. And when it is diagnosed, it would be diagnosed after an acute episode that is known as diabetic ketoacidosis, but further damage to organs, further complications of type 1 diabetes would be less common, rare at diagnosis. Whereas type 2 diabetes mellitus is often diagnosed when there is extensive damage to the tissues. So in 10 to 20% cases, the patient would already have multiple complications when he or she is diagnosed with diabetes. The treatment of type 1 diabetes is insulin that is taken intramuscularly, whereas type 2 diabetes mellitus can be treated via oral hypoglycemic drugs, weight loss, and if these two are not working, we may also use insulin. Now let's look at the biochemical picture which could be seen in type 1 and type 2 patients. So the plasma insulin level or the insulin in the blood would be either low or absent in type 1 diabetes, whereas in type 2 diabetes patients it is either normal or higher than normal. Insulin sensitivity would be totally normal in type 1 diabetes, whereas it is reduced in type 2 diabetes. Insulin resistance would be more in type 2 diabetes. There would be no resistance in type 1 diabetes. Plasma glucose concentration would obviously be increased in both type 1 and type 2 diabetes mellitus. So there would be hyperglycemia. That's why we call it diabetes mellitus. Moreover, the main defect in type 1 diabetes is the insulin deficiency due to destruction of beta cells or beta cells not being able to produce enough insulin for the body. Whereas in type 2 diabetes, the beta cells are producing insulin, but it is resistant mostly. Moreover, ketosis or presence of ketones in the blood is common in type 1 diabetes, whereas not common in type 2 diabetes. Basically, when there is no insulin in the blood, the glucose would be broken down by the liver, and it would be converted into ketones or keto acids. These acids, when accumulated in the blood, could cause diabetic ketoacidosis. So diabetic ketoacidosis is a complication of type 1 diabetes. Ketosis is common in type 1 diabetes, but in type 2 diabetes insulin is present, so that is why there is no ketosis. It is very uncommon. Now the pathophysiology of the diabetes mellitus, will just study this in the next lecture. Now there is an assignment for you guys. You have to do two things, okay? Let me write it down so that you can understand. So number one, history of diabetes mellitus. Where does this word come from? You have to search, write, and submit. Then differences between type 1 and type 2 diabetes. and differences between diabetes mellitus and diabetes insipidus. Now you have to submit these questions by, let's see, today would be 17th. Okay, so I'm giving you 5 days till 22 10 11 2020. So you have to submit this assignment, all of these questions by 22/11/2020. Okay, so this is your assignment for today. Now best of luck to you guys, and Allah Hafiz.